Welcome. My name is Linnea Wilhelm. I'm a UFCW 3000 union rep working out of our Spokane office. I support our members at Kaiser, Providence Sacred Heart, Providence Holy Family, and Ashley House. Before coming on staff at UFCW 3000, I was a member and shop steward at Sacred Heart, so I come from rank and file. I want to take a minute to share why we're so excited to collaborate with Dr. Gupta on his Healthy Conversations series. We all know that it's getting harder and harder to find trusted sources for information about our health. But our union has long served as a place where we can ask questions, get answers, and educate ourselves and each other about issues that impact our well-being. And as union members, we understand that at the end of the day, we cannot do well unless our coworkers, families, neighbors are also doing well. We are committed to taking care of each other. That is what solidarity is all about. This town hall series with Dr. Vin Gupta is one way that we are fulfilling our ongoing commitment to education and solidarity. We are learning together how to take care of ourselves and each other. Dr. Gupta is a renowned public health expert and pulmonologist who helped the country navigate our response to COVID-19. He serves as an affiliate faculty at UW's Institute for Health Metrics and Evaluation, and also as officer in charge of the Critical Care Air Transport Team at Joint Base Lewis McChord. Today, Dr. Gupta will be joined by Dr. Mariko Harper. Dr. Harper is a cardiologist who co-chairs the Cardiology and Innovation Council at Common Spirit Health, the largest nonprofit health system in the U.S. Aside from her many leadership roles, Dr. Harper also founded and currently directs the Hypertrophic Cardiomyopathy Center at Virginia Mason Franciscan Health. Now I'll turn it over to Dr. Gupta and Dr. Harper. Thank you so much for joining us.
Thanks, Linnea. It's so great to be with the UFCW family. I know we share this invitation broadly on social, so we might have some folks across the country. I think there's a Florida native. Thank you for joining us. I know it's late on the East Coast, but that just shows our commitment to wanting to learn together. So thank you for being here. We really value your time, and as Linnea said, this is actually my first time joining the UFCW family, UFCW 3000 family for one of these town halls. I know you had my colleague, Dr. Tyson Bell, for those that joined the first iteration last month. And I'm just so thrilled to be with you. I think the daily headlines that we're peppered with, that we see that are anxiety inducing, are reason enough and justification enough for why we're doing these types of engagements with all of you. I will say that, and before I introduce my dear friend and colleague, Dr. Harper, I, you know, throughout the pandemic, I had a chance to work with labor unions across the country and companies, and in addition to labor unions, and it became very clear that this type of direct engagement, we're going to be doing some in-person events later this summer, that this type of direct engagement can really help cut through the noise. Whereas, a social media tweet or a TV segment or, reading a medical manuscript, it just doesn't do the same. It doesn't have the same impact. And I think direct engagement on these issues that get so easily politicized, get so easily confused in the way in which we have our national debate and just the coarseness of our dialogue, there's no replacing it. And so that's why we're doing these engagements. We're trying to be very efficient with these engagements. I know it's late even for those on the West Coast, so we're going to continue to workshop how we can deliver this in a way that's convenient for your lifestyle and all the many things that keep all of you busy. So I want to be respectful of that. But without further ado, part of respecting your time is making sure that the folks that we bring to talk to you, I view myself as a facilitator of this series, but I want to make sure that we're bringing you the country's best healthcare people, whether they're journalists, whether they're clinicians, whether they're sort of non-clinical thought leaders, researchers. You're not getting those people at the upper levels of government. That's obvious. And I'm not going to make this about politics. That's not what this is about. But the reality is those people are not populating the United States federal government right now. And so that's why we're going to bring them directly to you through these types of town halls. Which is why, and segue here to again, my dear friend and colleague, Dr. Mariko Harper, who is probably, I was saying this earlier before the town hall started, um, is quite easily one of the smartest, just incredible diagnosticians I have ever met. Her and I were in the same residency class at the University of Washington in internal medicine. And in my commitment to give you the nation's best, I really think of Dr. Harper as in that ilk. And I'm proud that she's here for this conversation on wellness. Mariko, thanks for being here.
Thanks so much for having me, and thank you all for being here tonight. I'm really excited for this conversation. I obviously couldn't have put it any better. It's a real privilege to be able to have this conversation with you, but with all of you, right? Because ultimately, our oath is to our patients, our community, and like you said, cutting through that noise and having really frank conversations about what matters.
Beautiful. So without further ado, I'm going to try in this 50 minutes. So I should say, as a precursor, we had a lot of people register, and we're going to be syndicating this so that this is widely available on social. We're going to try to chop up interesting segments so that that we're going to try to make this as easy and hard hitting as possible to share for those that couldn't make it. But we had, gosh, 30 to 40 questions pre-submitted. So I'm going to bring some of those in. If you have questions that have popped up because you saw something on the news today or whatever, this is not just, we made it about wellness, but that's a pretty big umbrella term here. So if anything's on your mind, we're going to do our best to answer it. If we can't answer it, we'll get back to you, and we'll promise to get your contact information to get you an answer. I want to set that expectation that we're going to get you answers here, so that you keep coming back. Okay, so without further ado, what are we talking about here? And so these slides are just placeholders. They're not going to be revelatory in any way, but really it's about the discussion. And what I wanted to first tee up to Dr. Harper is, um, Mariko, you live, I see your very active lifestyle and social. I admire it. And I'm wondering your approach as a cardiologist that sees a lot of chronic disease. Um, we're always told to do so many different things that I feel like it's gotten to be just mush, to be honest. I'm just wondering how, for all of us, can you break down what you think are the most sort of top three things you would recommend, actionable tips to say avoid heart disease and to live as long of a life as possible? How do you really think about longevity?
Absolutely. Well, I think first we have to understand that most of cardiovascular disease is preventable. And patients are always surprised, right, to hear that because it is the number one cause. Heart disease and stroke are the number one cause of death worldwide, actually, but specifically very high rates in the United States. And yes, there is a genetic component, but much of it is preventable. And when we talk about prevention, right, in medicine, we talk about primary prevention and secondary prevention. So it's not just that you've already developed diabetes or you're overweight or that you had a heart attack. It's never too late to prevent the next event and to add to longevity. But one of the things I think that's so difficult now, especially in the era of social media, and these guidelines are even turning over, at a rapid pace. It's a 24-hour news cycle. Is where is the data, and then how do we customize it for the individual? It is so easy to feel overwhelmed by this laundry list of things that we need to do. But I always tell my patient in the room with me that one, we have to meet you where you're at, and anything is better than not, starting an initiative. And it's not about the gym membership per se. That might be great if you like doing that, but it's whatever you enjoy doing. So if we look worldwide, longevity, health, how do we reduce comorbidities? So comorbidities are the diabetes, the overweight, the things, the high blood pressure that lead to cardiovascular disease, heart attack, and strokes. And much of that occurs worldwide, not by necessarily expensive gym memberships, a prescription for working out, but walking. So let's start there and meet a friend, community, and getting out there and doing something that you like. So if you can only do 10 minutes at a time because you're short of breath, because your knees ache. Do that 10 minutes, maybe do it a few times a day. But I don't necessarily think that there's one prescription that fits everybody at all times. Now, that said, there's certainly data to suggest that the ideal for most healthy people is getting to the point where you can do what we call moderate intensity exercise. Something where if you're walking with a friend, maybe not completing a full sentence, but where you're a little bit labored, take a couple, take a breath in between a few words, but that type of labored breathing, try and do that for 30 to 40 minutes most days of the week, or try to get to 150 minutes. Those are sort of the numbers that we throw out. But I think meeting people where they're at, starting slow and going forward, and pick something that you enjoy doing, it goes a really long way. So that's going to be different for everybody, and that will change over time as your health status changes as well.
Mariko, I thank you for sort of focusing on the personal elements of this, because I do think that what I struggle with often, when talking about healthy living and sort of United States Preventive Service Task Force guidelines, is it does feel like it's a one size fits all approach in a world where we're learning that everybody has individual risks, whether it's environmental, what they put in their body, how they exercise, genetic. And it almost doesn't make sense why we have a one size fits all approach to diagnostics. And I say that as a tip because we got a few questions pre-submitted, and I appreciate for those that are watching in live, I saw a few questions already come through. I'm going to get to those. But I am wondering your approach to cholesterol. That's top of mind, so-called bad cholesterol, LDL, good cholesterol, HDL. How do you think about in this era of sort of direct to consumer, I can test myself for anything at any moment. Two questions. How often should people in theory be testing themselves for a lipid panel? And is it risk-based? Is it one size fits all? And then what do you think about statins? And sort of this question, some people think statins should be in the water. So are we underutilizing statins? Just wondering your thoughts on both frequency of screening and then also statin use.
So the history with cholesterol is that we've been all over the place over the last few decades. We've said everybody should just be on a standard dose. We've said we should be targeting certain numbers. We changed those numbers again, and we changed them again and again. As a cardiologist, and I think you're going to have a hard time finding a cardiologist who won't tell you that statins are some of the most potent drugs to reduce your lifetime risk of cardiovascular disease at a population level. The benefit that you're going to have with your statin will vary on what your risk is. But as we get older, since cardiac disease is the #1 cause of death, that risk will always go up. Do I think every single patient needs to be on a statin to be healthy? I'm going to be a little bit controversial and say not necessarily. If you're coming to me at 95 years old and you're healthy and you're having, and you have a different philosophy on life, I think we do need to have that conversation. And one of the hardest things about medicine these days is there's so much shame, I think, where patients feel like they've been told one thing. And if you're not exercising enough, if you're not the perfect body weight, if you have a history of smoking, you just feel like you can't even have that conversation with your doctor and be honest because you're going to be judged for it. Mm-hmm. So I do think we have to look at everybody as an individual. But generally speaking, I consider statins for the right person, which is, at a certain level of risk. We're not talking about starting them in teenagers for the most part, right? There are certainly some genetic conditions where that may reduce cardiac events. It's surprising, but a rare population of patients at very high genetic risk can have heart attacks at 20, 25. But for most patients, I think it's really important to have that conversation with your primary care provider or your cardiologist and look at the numbers for the statistics. And there are calculators that can help narrow that down. And then check your cholesterol level. I'm not going to spew out necessarily a certain interval because it depends on your health history, but that number changes with lifestyle, and that number changes with comorbidities and other medications. So frequently enough that we can make a change based on that. So in my world, if I check cholesterol every year on my patients on cholesterol medications or who have cardiac disease, because we're going to be using that number to guide an emphasis on other things we can do for prevention, lifestyle, as well as potentially titrating the dose of the medication. That number also matters a lot, especially what we call the bad cholesterol, the LDL, in predicting the risk for future cardiac disease. So if you've never had a cardiac event or a stroke before, or any other vascular event, peripheral arterial disease, for example, the statin is an investment in your future. So it's to start now to prevent the atherosclerotic disease, the plaque, the cholesterol plaque that builds up over decades in our arteries that lead to events years later. So starting early may reduce that risk, but that risk is going to be defined based on your age, hypertension, history of smoking, family history, and that number for the LDL cholesterol. And as we're finding out more and more, there's other factors in that family history, including other biomarkers within cholesterol. So it's not just LDL, but some of the lipoproteins and the specifics that allows us to get to a little bit more of a precision medicine approach in counseling.
I'm going to skip ahead on slides because you're I think we're going to go here first, and this is actually from your deck, Mariko. Can you talk? You went where I was going, which was these other tests. Well, but maybe before we go there, Carolyn in the chat had noted that she was tested, had high levels of cholesterol, had a conversation with her provider. And her provider wanted to start her on a statin. She wanted a first trial lifestyle therapy or lifestyle changes, exercise, eating, eating differently. And Carol, I'm paraphrasing, so by all means, if I get this wrong, tell me. But that was not the preferred approach of her provider, quote unquote. Those wouldn't work, and that it sounds like maybe starting a medication was the only way. Can you talk about are there situations where you would say, you know what, oh, we got to go directly to therapy because the level is too high or the risk is too high?
I do, but I really do try and take an approach that is not black and white. It's all about risk mitigation and having a conversation. I do believe that my role as a cardiologist is to build a relationship with the patient and to empower each patient so that they can understand the risk. And if we, unfortunately, we're all strapped on time, and a lot of us do think in black and white, right? It's medicine. The problem that I encounter with that is that we lose our relationships and we lose trust, right? And I don't need my patients to necessarily start a statin on day one, but if they've come in and they've just had a heart attack, we know that their risk of heart attack in the future is very high at a population level without being on a statin. If their cholesterol, their LDL cholesterol is above 190 and they're over the age of 18, there's really good data that over a lifetime we will be buying years and good quality years by being on a statin. Does that mean that we shouldn't be taking a pause to think about the other things? Not necessarily. Sometimes patients do need that time where we think about the contribution of the statin, think about the drug, build that relationship so that patients feel more comfortable in trying things with us, because not everything works for one patient. But yes, I think there's a big difference between primary and secondary prevention. And if you've had a mini stroke, we call those TIAs. If you've had a stroke, which is a blood clot or a blockage in the brain, or one of the arteries in the brain, or if you've had a blockage in the heart, then those are cases where we know that the chance of having that again is very high, and we can reduce that risk substantially by being on a statin. That said, to answer Carolyn's question, I think it's so important that we do focus on lifestyle. Do I think that there's not an added benefit to a statin? I often use the analogy. So we've got this graphic up here, right? So we have these arteries. I talk about arteries as being kind of pipes, right? It's the plumbing. We're plumbers, essentially, of the heart. And it takes decades for plaque to build up. And that plaque in the artery that leads to that narrowing and the blockage, which eventually leads to chest pain and heart attacks, doesn't occur overnight. But it's not always that it just happens from, a gradual percentage where it goes from 75, 80, 85, 90, and then boom. Sometimes we can go from a 30% plaque to a heart attack. Why? Inflammation. And inflammation is very difficult to study and very difficult to treat. We know that lifestyle things cause inflammation. Environment, smog, pollution, smoking, chronic illness, inflammatory conditions like inflammatory bowel disease, rheumatoid disease, diabetes. And we know that certain things that we have a really difficult time studying, such as exercise, weight, and diet, reduce inflammation. So I absolutely think you are making a huge investment, not just into your arteries, but in your overall health by being motivated and focusing on all the things that you can control, which is exercise, diet, body weight, really taking ownership over those things. Do I think that for many patients at increased risk for these events, a statin is that added icing on the cake? Yes, but it's a conversation and it's nuanced. And the most important thing is I think that we target multiple pillars and have a great relationship with our clinicians.
So well said. And what I will, I'll add on to that um, I often get asked about air pollution and the ways in which air pollution can impact your lungs if you have underlying lung disease or whatever it may be, asthma, COPD. And what I usually say is, the more we're learning, there's like a 5 to 6 year evidence base on air pollution as a risk factor for people ending up in the hospital, dying prematurely, aging faster. But we're actually still learning a lot more about it, as you know. And I don't, I loved your analogy of the 30% plaque can cause actually a heart attack out of the blue, because there's so many things that go into what might actually cause an artery to block. And it doesn't have to be, 30 to 40 to 50 to 60. It could be the environment we're living in, or something just happens unexpected. And I think the environment that we're living in right now, there's incredible heat waves coupled with wildfire smoke, coupled with all these exacerbants in our environment that didn't exist even 10, 15 years ago to the frequency it exists today. It worries me because there is a compounding risk that I don't think has been measured or studied all that well, that is unpredictable. And so somebody with that 30% clot in their arteries that is just not budging, when you think about all these things that are unpredictable in the environment around us, Mariko, it makes me worry that there's greater vulnerability out there than maybe 10, 15 years ago, when a lot of these risk factors were not as sort of close to the skin, or impacting the air that we breathe and the heat that we feel on our skin. But I don't know if you would agree with that.
Yeah, I completely agree. Now we have some studies from around the world where we know that pollution is impactful. We don't have a lot of studies here, but it makes a lot of sense. And I think there's a physiologic basis, a scientific basis to recognize that we are living in a time of a lot of inflammation, a lot of environmental stressors, and that all impacts our bodies, our cortisol levels, our stress levels, the amount of all this environmental toxins and things that may be around. We don't really know the impact. But what we do know, when I think about plaque, it's sort of a mixture of a few things. So if you've had a blocked artery, there are a couple things that we want everybody to take. One is a baby aspirin. And again, we're not recommending baby aspirin for everyone because everything has risks and benefits. And that's why it's so important for you to have your checkups and to get your risk refined by your physician so you can have this conversation. It is nuanced. But if you've had a heart attack, great data for a baby aspirin and great data for the statin. And the statin does more than one thing. The statin, so the baby aspirin thins the blood of some of those clotting factors, which is part of the blockage. But the statin is thought to do a little bit more than just lower cholesterol. It also lowers inflammation. We don't know exactly how, so it's really difficult to get into the weeds with this. But we know that unlike other medications, which have been shown to lower cholesterol, there's something special about statins that seem to have a higher magnitude of overall impact in preventing cardiac events, recurrent heart attack and stroke. And that's been sort of felt to be related to this inflammation question. But that's why I think we need to be really open-minded and have dialogue with our patients, that there's other things that cause inflammation. Vaping, smoking, environment, all this climate change, stress.
Yep.
And we may not be able to put a number on it because it hasn't been studied in the same way as statins have. But they're all really important. And I think there's a lot of things that we are empowered as individuals to take care of, and having those conversations and frequently having those conversations with your healthcare providers allows us to really refine that risk. And I've had many patients who at first they weren't ready to be on a statin. You know, we could talk about all the numbers, but they're just not ready. They've heard some bad things about statins. They're afraid. They want to do things naturally. That doesn't
Yep.
make you wrong, but we need to have that conversation and recheck your numbers and see how things are going, because things change over time.
Mariko, I'm going to slightly pivot, and then I just want for everybody to know I am tracking questions. I'm going to get to all of them. So thank you, and please put more in there. We did get a lot in the pre-submitted, and it's related to this conversation on stress, and so the axis of stress causing increases in, say, cortisol, and then impacting potentially blood pressure, negative impacts on your heart. And I'm wondering how, well, one, amongst your patients that see you, is that a real thing that there's an impact between sort of daily stress, harmfulness of stress on one's heart? Is there a gender difference? Does it impact men versus women differently, stress in the heart? And, I feel like the answer to some of this stuff might be self-evident, like, oh, how do you lower stress? But like, how do you really lower stress if you're somebody that has underlying heart disease and are at risk of, something like a clogged artery more so than the general population? Are there ways to intentionally, like almost like taking a medication, but not really, where you have seen been effective for your patients that you're worried about, that are like managing a family life and busy job? That, hey, gosh, this seems to really work. I'm just wondering if you have any tips for us.
Yeah, I mean, I wish I had a one tip for all. I think it's really difficult, and stress is a part of life, right? But the right therapy can be really helpful. Mindfulness techniques. There are things that people can do with just breathing that allows their vagal tone to increase. And so it just takes 10 seconds, right? So we talk about the parasympathetic nervous system and the sympathetic nervous system. These are evolutionary. Sympathetic is our fight and flight, right? We're running away from the saber-toothed
Hmm.
tiger. Our parasympathetic is our relaxation. That's what we call our vagal tone, or that's mediated by the vagal nerve. But when we're feeling stressed, and my patients come and they say, well, I feel like I'm having chest pain, I'm feeling like my heart's palpating or pounding, due to the stress, it can create this negative feedback loop. The more stress you have, the more adrenaline hormones. The more adrenaline hormones, your heart's beating harder and faster. That makes it feel painful and achy, and your heart rate's higher. That releases more hormones. So you can train yourself to break some of those cycles. A great therapist who does cognitive behavioral therapy can help some cases when it's more ruminating thoughts and it's having that physical impact. But mindfulness techniques where we just allow ourselves to breathe when we realize we're getting stressed out, and realizing that you can't take care of anybody, not your spouse, your family, the people under your responsibility at work. You can't take care of anybody if you're not taking care of yourself first. So sometimes those breathing exercises, just like 4 seconds of a deep breath in, hold it, and then a slow breathe out. Do that for about a minute. That's been shown to lower your heart rate and maybe increase some of that, relaxation hormones. And that sometimes helps with some of my patients who get into these ruminating cycles when they feel triggered by stress.
That's great. And I would add, I like listening to Headspace. They do, you can find it on your Apple Podcasts, or
Yeah.
it's an app, actually app store. And they have great, to your point, meditation, sort of 5 minutes on up of sessions. I'm not the greatest meditator, but you're right. There are
Me
moments where I
neither.
will do. Um, that helps. Summer, I found power washing to be an incredible stress buster. If you're not into lifting weights or running, if there's something there that can release some
Getting
of the
out
stress.
to
Yeah,
environment, right? Getting
you
to
get out.
get
Yeah,
out and
exactly.
dodge, get somewhere back to nature, turning off our phones, the media, we're always,
Uh,
um, we're constantly inundated. And while that's important, sometimes it's important to tune that off sometimes. They've had studies showing that having a a pet, an animal, can be really helpful too. So I think there's not a one size fits all, but I do believe that stress is an incredibly important factor in a lot of our ailments in modern day life, including cardiovascular disease. And while we have to accept that part of it is part of modern day living, there are things that we should be trying to do to target that. And a lot of it has to do with healthy lifestyle, friends, good sleep, and exercise.
It's great. It's great. I'm going to ask you some rapid fire questions. I'm going to pivot here. The first is from our friends that are asking us questions. I want to make sure that um, Sylvia noticed, I'm not a doctor, but meditation works, dot, dot. I couldn't agree more. I just wish I was better at it. But if you have any tricks for us or tips on how to actually get into a zone, Sylvia, that'd be fantastic. And please do share. Um, Pat Smith asks, is a stationary passive, I guess this maybe, I'm happy to take a first crack at this. Is
That's
a
a you question,
stationary
Dr. Gupta.
is a stationary passive pulmonary function test of value in the case of exertion trigger dyspnea? Sure. I mean, so Kat, I would say you have both a pulmonologist and cardiologist here, so we have you covered. But it's, I think, and if you want to do a direct message, by all means do that. But I think, and we can try, certainly try to provide specifics. But I think the questions will be, you know, if you can describe a little bit more about what you're feeling. Are you coughing? Are you having wheezing? Does asthma or run in the family? Do you have a smoking history? If the answer to all of those things is not really, um, I think a pulmonary function test that's passive would be a great starting point for your primary care provider to order to see. Maybe we're missing something, or maybe there's something that, it's high pollen season right now, or is there something in the environment that's triggering it if you're outside and experiencing the symptoms? I think if your pulmonary function tests look normal, you have no evidence of wheezing, you're not really, let's say you're not having a chronic cough, uh, no smoking history. Um, if all of those are negative and we don't think that, or is just not present, and we're sort of at a loss in the lung clinic. I just did this actually with Dr. Harper. And it was a family member. I went directly to her and I said, I don't totally know what's going on here. It was a family member that had a chest X-ray. We've had prior pulmonary function tests. Nothing was really elucidating to their exertion trigger or just a shortness of breath that occurred when they were exerting themselves. And so that's when, the referral to Dr. Harper, I think would make more sense. But breathing is difficult, no asthma. Okay.
Yeah, I mean, right? I mean,
Yeah.
we go back and forth, pulmonary, cardiology, pulmonary. No matter where you start, it can be really difficult for either of us to figure it out. Those questions help, but it can be the heart too, sometimes.
Yeah.
So I think that's the thing, is that people think that you have to have crushing chest pain to be having some heart symptoms. And while those are still the most common symptoms of a coronary event, or a heart blockage event, especially in women, but with a subset of men as well, the main symptom is typically exertional or stress induced, but exertional shortness of breath. So that breathlessness, where if something's changed, I do tell all my patients the very best thing you can do to keep your heart healthy, other than all the things, the prevention things, is do your daily stress test. If you're walking around every day and something's changed, that's a reason that you should be reaching out. So sometimes sometimes it is something cardiac, and sometimes it's something cardiac but not an artery thing, and sometimes it's lung. But those tests, we go back and forth. I refer a lot to pulmonary when the heart tests are normal, and I get a lot of referrals from the lung docs when the lung tests are normal, and sometimes we find something on the heart side.
Beautiful. We're going to aim for rapid fire here in the sense of coronary calcium CT scans, Mariko. Yes, no, and if yes, for whom? If no, why?
So
Who should be getting them?
so they're low radiation, resolution CT scans. It's about a millisievert of radiation. So we're talking about a diagnostic mammogram type of radiation. No contrast, takes about 10 minutes. So as far as tests go, simple. It can be good to risk stratify your risk of future heart disease. These are preventative tests that help refine risk. They are not tests for people who've had heart attacks before, who have stents. And they're not the right test for anybody who is having symptoms of a possible cardiac event. We might need a different type of CT scan called a CT angiogram, a formal angiogram, or something like a cardiac stress echo, like Kat Smith is mentioning they're having. So those are tests for symptomatic patients. But if you are in relatively good health, and I use it as a good test when we're thinking about potentially upping the game and adding a preventative statin. We're not seeing all plaque. We need enough plaque that it hardens and calcifies and turns bright that we can pick it up on a CT. So you can have a normal calcium score and have a heart attack the next day. So that's why we don't use it when people are coming in with concerning symptoms. But it can help refine the risk if you have these borderline cholesterol levels. You're getting to that age where we're looking at these calculators and your primary care provider might be saying, well, maybe we should start a statin. Your 10-year risk of having a heart event is about 8 or 9%. These calcium scores in that patient population can be very helpful to put you into a different bin. So if it's 0, especially if we combine it with a blood test to check inflammation called a high sensitivity cardiac specific CRP, we can say, hey, as long as you don't have any outliers, right? We're talking no diabetes, no family history of like really genetically mediated heart disease. If you have a calcium score of 0 and no symptoms, then you can maybe buy yourself a good 5 or 6 years of being relatively low risk before we consider redoing that again, and maybe be able to refine your personal risk of future cardiac disease. It's a bell curve, so you're going to get a number. If that number is any amount of calcium, that means that calcium's been there for a few years. And for most people, any amount of calcium means that the non-calcified plaque is even more than what we're picking up. And even if that number is low, a statin, in addition to a healthy lifestyle, may reduce the risk of that progressing. I do not recommend these scans if you've already been on a statin. We know that one of the things that statins do, they reduce your risk of cardiac events, but they can actually make that calcification more prominent. It removes the inflammation, but it hardens it. So you can have a big bubbly, kind of like a festering wound type of inflammatory plaque, and it can kind of shrink and shrivel it down, but it can actually increase the amount of calcium, that hardening of that. It's more stable, less likely to erupt, but that's why it's not as reliable and it hasn't been studied in a patient population already on statins. But if you're no symptoms of chest pain or shortness of breath concerning for an event, you haven't had an event and a clear-cut indication to be on a statin, you're not considered very high risk, it could be a good conversation piece when we're having that conversation of when to consider what we call a preventative statin. And sometimes even for my patients who aren't quite ready to be on a statin, seeing that result, realizing that on that bell curve, despite the fact that we're doing everything right, they don't have any other risk factors, no sleep apnea, they don't smoke, they're not overweight, they're exercising 5 days a week, they eat a plant-forward diet, they're still above the curve, then we say, well, that might be the genetic side of things, and maybe that statin can help, further push you towards longevity and health.
Wow, we have covered a lot of terrain. That was fantastic. Thank you, Mariko. I am going to move us forward, and I want to come back to a question that was put into the chat. That I'm going to give you a second to catch your breath here, and I'll take a first crack. But please improve on it, Mariko, if you think I have anything wrong here. It is on from Amy Sloan. Amy, we're gonna do a hard pivot away from cardiac for a moment and talk about today's news. How will, quote, the CDC panel targeting flu shot ingredients blasted by anti-vaccine activists affect our ability to get the flu shot? My family and I always get the flu shot annually. Amy, great question. And this is personally, and I'm sure I'm speaking on behalf of both Mariko and I, this is just the epitome of frustrating in the sense of there are so many meaningful debates we should be having as a country on health policy, that there's a Democratic approach, there's a Republican approach, there's probably a middle of the line, down the line approach on so many things, and that we do not have right. Thimerosal, which is a preservative, It's a mercury-based preservative, so there's a low concentration of mercury, the chemical mercury, in what is an organic preservative. It's very low concentration, and it's a preservative to keep that vaccines safe from bacterial contamination. That is what it does. There is no problem with thimerosal. So in a world where we have a million crises that we could be talking about that would be deserving of the Secretary of Health's time, this is not one of them. And yet, this was almost preordained that we were going to talk about it today at this advisory committee on immunization practices, because the secretary, again, just stating the facts, not trying to get in any way, partisan. The secretary has made his entire last three-decade life talking about this specific chemical as a cause for autism and the increasing incidence, which is a separate topic. Autism diagnoses are increasing for a variety of explainable reasons. Thimerosal and flu vaccine is not in any way one of them. Here's the rub. Nearly all vaccines in the United States do not have this in our vaccine supply anyways. We get flu vaccines through single dose vials. That means every glass vial vaccine that has flu vaccine in it is a single dose. So it's not an issue. We're not constantly coming in and out of that vial, multi-dose vial with a needle and potentially introducing a bacteria and causing that supply to get infected and then passing on an infection potentially to a patient. Where this is present is in the global supply. And so, which doesn't impact us, but in global supply chains, some of which are made here, thimerosal keeps a multi-dose vial that may say go to South Asia or Sub-Saharan Africa, places that rely on it because they don't have a ton of freezer capacity. So they need vials that can hold multiple doses, not just one. They need thimerosal, low doses of thimerosal that have very low concentrations of mercury to keep that vaccine supply safe from contamination. The fact that this was done today, all that does is it injures yet again vaccine resilience, supply chain resilience, not for the United States, thankfully in this case, but for places that are desperately in need of flu vaccine that don't have enough, that don't have manufacturing capability in those places. And now here we're this completely invented problem that is not a problem. It's likely going to impact supply globally in places that rely on these multi-dose vaccines. So, Amy, to answer your question, not something that we have to worry about, but this is an invented problem that is only going to cause more problems in global health. And again, this is just a problem of our own creation. So unfortunately, that's the answer to that. And just to make to I am being comprehensive here, Amy Sloan, thumbs up right back at you, Amy. Mariko, Mariko, I guess throwing it back to you, I am curious, what would be your response and what if it's a patient that you're seeing in your cardiology clinic or just broadly? I know you do a lot of public facing work and you're fantastic at it. How are you navigating our health information environment? I don't think any of this is new. This was throughout COVID, misinformation. People get their health information out through their favorite podcaster, not through the New England Journal of Medicine or the CDC
Exactly. Yeah.
website. And it's like, this has changed from when you and I were residents. It's a very
Yeah.
different information environment. I'm wondering how you're coping and adapting.
It's hard. I think even in the last 5 years, the patients come in with a lot more skepticism, confusion, and they don't know who to trust. So plug number one is go to your physician. It's been a long time since you've seen your physician. Make that appointment, even if you're feeling good. Just ask those questions and figure out from the source. And this really isn't a political debate. In cardiology, we take care of really sick patients. Our patients skew older. They have cardiovascular disease, or they have risk factors for cardiovascular disease, and that's why they're here to see us. We are so lucky that we have vaccines that can reduce the risk of major illnesses that in patients with cardiovascular disease are a major source of cardiovascular events. I do think it's really important for us to listen and to go in there non-judgmental. I hear a lot of things, and sometimes patients are just confused. They've had so much misinformation that
Sure.
coming from a spot of fear. But I think vaccines are not political. I think they're one of the greatest inventions in keeping us healthy and our communities healthy. And when it comes to our vaccines that are recommended for my patients, I can't convince everybody, but usually if you have a nuanced conversation and you figure out what their fear is, oftentimes it's based on misinformation. And look, even with COVID and COVID shots, right? Everything has a little bit of risk. Living every day, getting in your car has a bit of risk. Eating organic salad can have a bit of risk. But how I mitigate it is by looking at the data. And we know that flu is a major killer, especially in patients with comorbidities such as heart and lung disease. And
Yep.
in our hospital, we both work in the hospital, in the ICU. If you have these preventable illnesses, if you haven't had your flu shot and you get influenza, it can end badly. And I think if you're not on the front lines, if you're not there, I think it can be hard to imagine how demoralizing it is for us knowing that there's something preventative that we could have done. So I try to go in without a lot of judgment and really listen. But the vast majority of time, it's not an allergy. The fear is from something that there's not a lot of science behind. And when
Sure.
we get into the statistics for most vaccines, especially in the population that I'm talking about in cardiovascular, there's so much data that we can be reducing hospitalizations and cardiac events that fortunately, I think I'm pretty blessed that I have great relationships with most of our patients, and most of them understand. Many of them have lived through heart events. They know what it's like being in a hospital or an ICU, that this is not the issue for them. But we know we take
Right.
care of everybody, but it's challenging, and it's becoming more challenging day to day. What about you, Vin? What do you tell your patients?
Mine at this point are usually intubated, and so
Yeah, they're in the hospital.
so but you know, when I have those conversations, say with people that ask me these questions, I try to do follow your playbook, which I think is beautifully said. And you're right. It's just it's hard to scale, you know, and I think for everybody on this call is one thing that I don't think has been appreciated but it's very insidious is uh, this new advisory committee has said that pediatricians need to engage, or patients or parents should engage in shared decision making with their pediatrician on whether or not to vaccinate their children against, say, measles, mumps, and rubella. That is something that is now being recommended by our Secretary of Health. And I think where it's challenging, I'd say, to have these direct conversations, at least what I've heard, you know, my wife's a pediatrician and others say that are dealing with what's happening in Texas, they come back to me and say, you know, Vin, we just don't have enough time to engage. Just like I'm sure you, Mariko, there's only so many things you can tackle in your 15 to 30-minute visit potentially. And what was previously like ACIP is going to recommend XYZ. Now it's like, no, we're going to engage in shared decision making. That's hard for
I agree. I mean, I am a
yeah,
huge proponent for shared decision making, right? This idea
yeah,
that we as physicians give our expert opinions and we listen and we come up with a plan that is beneficial for the patient with the patient's input. But their shared decision making, that ideal is for things where there are multiple options that may
yeah,
be valid. So when I have patients who want open heart surgery versus a clinical trial versus high risk open heart surgery, clinical trial, or a medication that may or may not work with side effects. That's a great opportunity for shared decision making. Lots of risks on both sides, lots of potential benefits. We need to have that conversation with the philosophy of the patient. Vaccines, there's a lot of data. I just don't know if that's where we need to be spending our time diving into things. I think it's just very clear that for most people, vaccines, as somebody said here, saves lives, and you're not just yours, but your community. So um,
yeah.
I just think there's so much more important things that with the limited time we could be focusing on. And it doesn't mean that it's not right to have those conversations, but the vaccine thing is a lot more clear cut than what I typically expect for shared decision making, which is the more nuanced conversations.
I couldn't agree more. I could not agree. Beautifully said. I'm going to try to get to three topics or three specific things. And so, in our 6 minutes left, so I want to be mindful of your time, Mariko, and everybody's time here. Number one, rapid fire, is a GLP-1 truly good for your heart? What's your take on that?
Possibly. Again, I think obesity is complicated. The relationship between obesity and cardiovascular is complicated. GLP agents have been shown to reduce risk of cardiovascular events in patients with cardiovascular risk factors and disease. Is it more than diet and exercise? Not necessarily. As a complement to diet and exercise, perhaps in the right patient population. I think we need
Okay.
more data. I think it can be, but it has to be as part of a plan, not just on its own as a substitute.
Okay, great. We're going to stay in the heart for a second. This is about COVID. What's your take on, or is there consensus on the long COVID and its impacts on long-term heart health? Wondering what your take is. If somebody has long COVID, do you put them on a blood thinner? Wondering, or aspirin? Kind of, how do you manage that?
We're seeing a lot less long COVID these days, new cases, and most of it does seem to get better. That's my sort of personal experience, and I don't have a long COVID clinic. I don't generally put them on a blood thinner. That's not
Okay.
my practice. I just don't think we have enough data, so it's case by case. But most patients with long COVID do have a meaningful recovery and improvement over time, and from what I experience in the cardiac world.
Great. Okay, perfect. I want to go out on this, and then we're going to do, I know there's a few sort of asked to summarize the key ways to stay healthy, heart health, and I know we've talked about a lot. So what we're trying to norm coming out of this, just for the audience, and I know for our social audience, there's a lot of questions that came in beforehand, is we're going to send out some clips. I know Mark and team are going to help us with that. We're going to try to post a blog within the next week that summarizes all these amazing tips that Dr. Harper has given across heart health, criteria for statin use, criteria for thinking about, say, coronary calcium scans, GLP takes. We'll give an update on ACIP. And I do want to actually, Mariko, end on something that I feel like we'd all get smarter learning about your take on this new age revolution of direct to consumer tests that are crazy expensive, but I think has generated a lot of curiosity. And specifically, I'm wondering how you think about um, what is inaccessible to, say, the vast majority of Americans, but this $2,500 Prenuvo full body MRI scan specifically. And uh, do you have a point of view on it? If a patient were to ask you about it, how would you answer, whether someone should or should not do it? Sort of take affordability aside for a second. Just
Yeah.
if this was available to the masses, is this something that if this was available to the masses, would we all be doing it, or would it be just picking up a bunch of stuff that would cause a lot of testing and a lot of problems?
Yeah, so I think there's different lenses to look at it. I mean, I can definitely see the appeal, right? It's intriguing. I think we also do, but we do have to be really cautious of what is it finding. And I do think what we call these incidentalomas or these incidental findings, uh, yeah, we are going to find a lot more of them. And do we have the resources to go in and to go down each of these rabbit holes? I think it can lead to additional testing. I think it can potentially lead to additional hardship, emotional and financial. But there will also be cases where we find something new. So this is
Yeah.
something that's an evolving area. I think it's something that for some people, we might be finding something. This is maybe from the innovation standpoint, can be interesting and maybe helpful in the long term. But right now, like with a lot of genetic testing, there's a lot of nuance. So you do need a care team, because what are you going to do with those results? And
Right.
that's a problem that I foresee with a lot of it, is what's the next step? What about you? What do you think, Ben?
Yeah. No, I that's exactly my point of view too, is even if you could afford it, is what do you do with the information? And I've heard all these anecdotes. Oh, it detected this. Oh, it detected that. And there are some hero stories where you're like, wow,
And those are
somebody
going to be really highlighted, right? But then what
that's
about
really
that you
exactly.
start developing the day after that you're falsely reassured and not and ignoring the symptoms for? So
A hu- This is it's almost, it reminds me of the problem of the, a lot of people get their information from their favorite podcaster now, and they're directing them to these direct to consumer, uh, very expensive tests, and I think it's putting people down a rabbit hole that can be quite expensive, not physician directed. And I think, to me, it's just, I worry that it's going to take 10 to 15 years to course correct that. Oh gosh, fif- after this large data set is accrued, people, it turns out actually very few people benefit from this. But then
Yeah,
maybe for those very few people, we can create a sort of a reimbursed pathway so that people can get this. But
I mean,
I
I
can't
would
imagine
like,
this.
yeah,
Yeah,
the philosophy of it, I think is great, is that we're innovating to the point where we could pick things up earlier, right? And
right.
you need to get better with their screening, but we know with any screening test, there's going to be false positives and false negatives. We're going to miss things, or we're going to pick up things that aren't real. And how is that going to be economical for a system? How is that going to be emotional for our patients? Are we going to be giving patients false reassurance so they're not going to be seeing their cardiologist when they're actually having chest pain the next day? I think there's just so much there. So I do have my concerns that, and the next step also could be radiation, another CT scan, or even a biopsy, a needle, and so everything has risk.
It's never ending.
It's important to have, I think, a medical team with a real human being who's been to medical school as part of that team, I think, to guide your conversation um, in these novel approaches.
Agreed. Mariko, I can't thank you enough. I can't thank, your expertise is just so evident and so articulate. We're going to get syndicated clips of all the heavy hitting things you said. I'll put together a post for everybody that's shareable since I know it's late. So we're going to get a lot of hits on syndication. But this is really useful information that I think often gets missed, especially in our course public discourse on health right now. So with all of that said, Linnea, I throw it back to you. Mariko, thank you.
Yes, thank you, everyone. Thank you, Dr. Gupta and Dr. Harper. We so appreciate you coming here and sharing with us. It was a great hour with you. I want to make sure everyone knows that our next meeting will be on July 29th at 3:30. So watch on our website where you can fill out the link to join for the 29th. And then if anybody has any questions, please let us know. But thank you so much for joining us, and we will see you in July.
Thank you, Dr. Harper, Dr. Gupta.
Thanks for having
Great
me.
discussion.
Thank
Thank
you.
you.
Amazing.
Thanks so much, everybody. Have a great night.
Good night.
Night, everyone.
Good night.